has always been quite a profound issue, even for our young children. And particularly when I look at the children, so I'll try and work through the ages. When we were growing up, it was a very different world. Now our children are subject to lots of information and peer pressure. And sometimes that manifests itself in very different ways, particularly with young girls who are quite conscious about their way they look. At one point, my daughter was posting a selfie every 10 minutes on this, and I had to sit her down and say, it's not, you don't have to be validated by your peer group. And then we had a lot of work to do with her in trying to encourage her confidence. The biggest cause of death in the under 30s, unfortunately, in women is suicide and injury to themselves. So that's something that we really have to look into with a much wider lens, particularly more so now that we've all been in lockdown. We all know that some of these issues are going to be quite challenging to deal with, particularly because we don't have enough resource or funding in certain areas to deal with mental health. And so that's something that we really are pressing for, because we're already calling it a tsunami of mental health issues that are going to await us in the autumn in June when we come out of lockdown. As women, we are, particularly in your sort of middle life, I could say, particularly if you are family women, there are some members who have dual responsibilities. And so coping with the demands of the home, the children, and perhaps elderly parents and a job, all these things really are quite profound and quite difficult for some people to deal with, particularly, again, I'm going to mention the lockdown, where your normal mechanisms of support, whether they're family or friends, have been cut off from you by default because we've had to all self-isolate. So we're seeing a lot more depression in this area as well. Dementia is something I would really like to touch on if I can. Dementia, believe it or not, is the leading cause of death in both men and women. And the reason why I'd like to touch on this a little bit more is it's seen as a rather taboo subject in a lot of our cultures, where we don't want to discuss it, or we just not necessarily sweep it under the carpet, but it's something that we perhaps feel shamed about and find quite difficult to talk, not even within our own families. So it may be that our own family members don't know that somebody is struggling with issues with regards to their memory. And the challenges that we have is, which is similar to the vaccine, so I'm going to come back to that, is the reason why I'm so passionate about research is one of the questions you always get asked on a vaccine webinar is, how many Black people was the vaccine or this treatment tested on? Now, I'll look at myself. I've never been involved in a trial that involves any medication. And that's not because I haven't wanted to. Maybe it has, because we did have the AstraZeneca trial just around the corner from here, but I wasn't sure. And I think I was afraid, if I'm being honest with you. And that's as a medical person coming to you and saying, I was fearful. So I think when you look at all the trials, whether it's Pfizer, Moderna, or AstraZeneca, there was only about 8 to 10% of Black people involved in these trials. So similarly with dementia, with all the dementia trials, it's very rare that you have Black people involved in these trials. But it's really important that we consider our choices, because if we want these treatments and we want to know the effect it has on us as Black people, we won't know unless we get involved with particular studies. There's also lots and lots of supportive elements. Only last week, I found out about an organization called DACE. So they're the Dementia Alliance for Culture and Ethnicity, run by David Truswell. And he has a whole forum of supportive resources for Black people who are struggling with issues of dementia. And also, it's not just dementia. There are other mental health disorders that do affect us. So things like schizophrenia or psychotic, or even psychosis or substance misuse. They're all relevant things that we really need to have more open and honest discussions about, because particularly with our men, and I know this is a women's forum, we do know that there are a lot of issues surrounding mental health. Oh, shall I do the next slide? So screening is one of the big areas in primary care that we're also involved in. And unfortunately, there was a period at the beginning of the year where, because we were firefighting with the pandemic, a lot of our screening stopped. So cervical screens and breast screening stopped. And if I can come away with anything, I would encourage anyone who's watching today, your GP has not closed. There was this perception that GPs were closed and you weren't able to see your GP. And I do know people who've had genuine difficulties getting in to see their GP, so I'm not going to ignore that. However, the way we are practicing now is very different. So often you'll get a phone call first, and then you'll be triaged. So a doctor will speak to you about your symptoms and will bring you in probably, if it's an immediate urgent problem, we'll see you there and then. Otherwise, they'll book you in for a routine appointment, be it that day or later on during the week. So it's really, really important that once you're eligible, particularly for your breast screening, which is age 50, you do try and attend, because there's a significant amount of people who leave it too late. And it's just really quite sad when there's something preventable that we could have stopped. Similarly, for cervical screening, when you get to 25, you'll be invited for a screen. And again, it's important that we do engage with these processes. It is difficult, it is uncomfortable, it's not a pleasant thing to have, but we do know that if we can pick up these cells early, the risk of you developing things like cervical cancer the impact of picking that up is tremendous. There are free health checks for the over 40s, but they are, I think, being phased out shortly. And I think, again, that's because of resource. And there is a screening program there's a bowel screening program as well. I won't go into everything on this slide, but the things that I probably will talk about that really concern me is our risk of things like high blood pressure, which we do deal with a lot, and obesity and diabetes. Often people think these things aren't going to happen to me, but particularly my mum's from Southern Africa, my dad's West African, so their diets, it's been an ongoing battle, but we're getting there slowly, trying to change the way they eat, because we do food is a very, trying to be diplomatic here, food is a very central part of our culture. And that's a good thing because it brings us together. But you can go to a meeting, but that meeting sometimes is judged on whether there's food or not. And even if there is food, what kind of food is it? So, we break it down to different levels, but we do need to start thinking about the choices we make, because particularly if you've got central abdominal obesity, so if you're gathering a lot more weight around your middle area, that's a real high risk factor for you developing diabetes and heart disease. And heart disease, there's lots and lots of studies. There was a thing on BBC a few weeks ago, when women present to their GP with symptoms relating to their heart, often the GP, so we're guilty of this, tend not to take it as seriously or treat it as seriously as we would do with a man. So for example, a man comes in and says, oh, I'm a bit tender around here every time I go for a walk. So the GP would tend to often think, oh, okay, I'm thinking heart here. Could it be heart related? And we do all the relevant investigations and tests for that. A woman of similar age, maybe in her late 40s, particularly in the 40s to 50s, will come in and will be thinking about, are you a bit stressed? Or, maybe it's a little bit of acid. So cardiac disease would be a bit lower down on their radar. So it's really, really important we take care of ourselves. Okay. And lastly, I thought I really do need to mention domestic violence, because as we all know, unfortunately, in the last year, again, because if you're in a situation where you physically can't leave the house because you're self-isolating for whatever reason, or you're in lockdown and your abuser is in the same premises as you, the rates of domestic violence have really shot up. And the government is trying to emphasize to people that if you are a victim of domestic violence, the current government guidance does not apply to you. You must get out and seek help. There are some certain schemes you might be aware of. One of the most common ones is Ask for Annie. So there's about 240 pharmacists that are involved in this scheme. They've used the word Annie because it sounds like somebody's name, and it's action needed immediately. So if you see that sign, Ask for Annie, at a pharmacist, I think it's Boots are mainly involved with this scheme. They are specifically trained to take you to a side room where you are sat down and given a phone to ask for help and directed to some right resources. And again, I'm conscious that I don't want to just skim over this, because we could have a whole session on this really, but I am conscious that I'm seeing a lot more women who are really struggling in certain situations, but you need to know there is help out there for you. So I think I've probably said enough, but I'm sort of happy to contribute to any questions. If anyone's got anything in the chat that they want to put in, I can put the link for the dementia website that I talked about for the supportive resources, if that's okay. And thank you for having me.
Thank you very much, Margaret. That was fantastic. And we definitely would like the link for the dementia. I was going to ask you that when you finished. That's excellent. So what I'm going to do now, I'm going to introduce Ibrahim. What we will have, and what we commonly have, is lots of questions, some from our YouTube watchers, and they will our team will put that into the chat for us, and we'll have those questions. And we also generally tend to have quite a lot of questions in the chat as well. So we'll come to that after Ibrahim's talk. So I'm delighted to also welcome Ibrahim today. He is the president of MANSAG, as I've said, and I'll let him introduce himself. Thank you, Ibrahim.
Thank you very much indeed, Ngozi, and thank you, CAHN, for the kind invitation. It's a privilege to be here. I'm conscious of the fact that Monday is going to be the International Women's Day, and when Ngozi asked me to make a presentation which will reflect something about women's health, I thought, well, we've got a GP and a consultant. In the same way, we have a barrister and a solicitor. A GP, we have an overview of everything, but solicitor will be very specific. So in the same way, because Margaret has covered quite a large ground, what I proposed to do was to pick a single topic. And what I did yesterday, asking my secretary to try and ring 7 of my patients who are of African origin in terms of topics. And 3 topics came on top: fibroid, recurrent miscarriage, and depression. And I said, well, I'm not a mental health individual, so that will not be an area for me. So what I propose to talk today is going to be on recurrent miscarriage, because it's very common. So I'm going to start by talking about causes of miscarriage. Can the miscarriage be predicted? And what should a couple do if they experience recurrent miscarriage? And how do you help women who have had this experience? And is it possible for them to carry a full-term pregnancy? And I hope to maybe cover this ground maybe in about 10 to 12 minutes. So if we start with recurrent miscarriage, a miscarriage is the loss of any pregnancy before it is developed enough to survive, usually before the first 24 weeks of gestation, 24 weeks being maybe the earliest area that babies can survive, but the goalpost is changing. I don't want to go there. In a miscarriage, the loss is very spontaneous. It's never been caused by either medical or surgical intervention. And there are 2 types of miscarriages. It can occur early, it can occur late. Early miscarriages are those pregnancies that are lost in the first trimester. And 1 trimester is about 13 weeks. And look at it as 3 months. Unfortunately, 1 in 5 of pregnancies miscarry in this way. Late pregnancies, those are the ones that occur after 3 months of pregnancy, but before 24 weeks. Those are the ones that are called late miscarriages, and they are less common, 1 in 2%. So what is defined as recurrent miscarriage? And this varies from countries to countries. In the 4 nations of the United Kingdom, recurrent miscarriage is when miscarriage occurs in 3 consecutive cases or back-to-back. However, guidelines in the US, in Europe, they suggest the diagnosis is slightly variable. They are probably more generous in the sense that any 2 consecutive pregnancies that occur even if there's a normal pregnancy in between them, is regarded as a recurrent miscarriage. So how common is recurrent miscarriage? If you use the UK definition, i.e., 3 consecutive miscarriages occurring, the rate is about 1%, 1 in 100 of couples trying to have a baby in the UK will fall into this category. So what causes them? There are many causes of recurrent miscarriage, but unfortunately, it is not always possible for doctors to determine why it happens. We know miscarriage can be very sad, distressing, and sometimes very scary experience. The good news is most couples who have recurrent miscarriage, they have a very good chance of having a baby in the future, especially if no results have been found, i.e. if the investigations are entirely normal. So let's briefly look at some of the potential causes. The first thing I'm going to talk about is biological clock. The age is very crucial. The age of the mother and the father are both important, and the age is inversely proportional to the risk of having a miscarriage. What do I mean by that? It is more common in older women, and the risks are higher the older you are. For women over 40s, for example, the risk of miscarriage is about 50%. But there are some known blood disorders. The 2 commonest ones are the ones called APS, which is antiphospholipid syndrome. Now, most women who have undergone miscarriages will be familiar with this term, and they will also be familiar with thrombophilia, but I will explain that into some detail. So in APS, it happens when your body immune system makes abnormal antibodies. And these antibodies, they attack fats, and these fats are called phospholipids in the blood, making the blood more sticky and unfortunately more clotty. And that is why this condition is often called sticky syndrome or sticky blood syndrome. And sometimes it could be referred to as ooze syndrome. This is the individual that first discovered this condition several years ago. Unfortunately, there's no cure for APS. What medication can do is to reduce the risk of blood clots. The second blood disorder is that of thrombophilia. These are inherited conditions in the blood which make the blood very clotty. And there are a number of factors. The 2 commonest ones are factor V leading and also factor C. But there are also genetic factors, chromosome factors. In about 2 to 5% of couples with the condition, one partner will have an abnormality of one of their chromosomes. Chromosomes are genetic structures within our cells, which contain genetic information that we inherit from parents. Although this abnormality may not affect the parent directly, but it can sometimes cause a miscarriage. If you then deep down into other abnormalities, look at the abnormalities of the womb. That is where the pregnancy is carried. The number of abnormalities can occur, ranging from abnormality of the uterus itself or the contents of the uterus, containing fibroid, polyp, or maybe some inflammatory changes. Commonly, many of the specialists are coming with the idea of what is called NK cells. And I get these questions come to me very often, particularly in patients that are being investigated for infertility more so than in recurrent miscarriage. Natural killer cells. These are type of blood cells similar to white cell that we find. And what they do is that it's believed that these NK cells, especially when they are present in the uterus, they contribute to infertility and miscarriages. And I come back to that because it's not very common. The test is not available in the NHS. It can be very expensive. And there are 2 of them. There's NK cells within the blood system, and there are some specific NK cells within the uterus. The one inside the blood can be taken by blood test, but the one in the uterus has to be by endometrial biopsy. So can we predict miscarriage? Yes. Older parents, especially when the woman is over 35 and the man is over 40, this age increases risk of miscarriage. We also know that miscarriage is increased after successive loss. So the more miscarriages you have, the greater the loss. And there are some other comorbidities, medical conditions like diabetes, SLE, and maybe lifestyle conditions, smoking, excessive alcohol, use of recreational drugs. This increase the risk of miscarriage. So what should a couple do after experiencing recurrent miscarriage? The first thing will be to get assistance, embark on lifestyle changes, such as good diet, weight management, avoidance of smoking, alcohol, or recreational drugs. Let me briefly just talk about investigations that can be done. I talk about abnormalities of the uterus. So examination of the uterus using ultrasound scan is very useful. This is probably the simplest one. It can be done through transabdominal ultrasound or through transvaginal one. And increasingly, the technology has improved. And if you have a 3D scan, it gives a better overview than ordinary 2D scan. So if there's some form of abnormality from ultrasound scan, other intervention might become necessary, such as hysteroscopy, that's passing the camera into the womb, laparoscopy, passing the camera inside the abdomen and pelvis to exclude abnormalities of the uterus or some intrauterine pathologies. In late miscarriages, an ultrasound scan can be useful to exclude a condition called cervical incompetence. This is not common in very early miscarriages. They tend to occur late in miscarriages. Although most of the investigations that I'm going to describe are performed pre-pregnancy, in case of cervical incompetence, they need to be performed in early pregnancy. So the blood tests that are required, those are the ones to screen for APS or thrombophilia. For APS, you need to have 2 antibodies, one of the 2, either anticardiolipin or lupus anticoagulants. I'm sorry I'm mentioning these names, but these are the names that are going to be used during the investigation, and it's important as lay women and laymen to be familiar with them. The most frustrating thing about testing the antibodies is that you need to have 2 tests, and the 2 tests will have to be 6 to 12 weeks apart. And when the couple is suffering from miscarriage, waiting during this period of time of testing and retesting can be very frustrating. In case of thrombophilia, 2 common blood tests that you need will be factor V Leiden and factor X. And occasionally, some antibodies from the thyroid might be used. The next thing is that of chromosome analysis for the parents. You need to have some blood tests to check your chromosomes, because some genetic abnormalities can increase the risk of recurrent miscarriage. So I'll finally start by talking briefly about the treatment. You can classify the treatment into general and specific. General treatment is that of general health care, lifestyle factors, avoiding smoking, weight management, because if you're overweight or underweight, those 2 conditions can increase the risk of miscarriage. Reduction of consumption of alcohol, regular exercise. But we should not forget the role of psychotherapy in the form of psychological support or counseling. It doesn't have to be a formal psychotherapy session. It could be maintaining link with your family, using your, what is probably called, using your capital, your social capital to support you. But if it's very serious, then maybe specialists will be required. Specific treatment will be aspirin and blood thinning medication in APS conditions. These are low molecular weight injections. The injections are administered around 16 weeks of pregnancy, but low dose aspirin could be started as soon as pregnancy is achieved. Usually low dose aspirin about 75 milligrams. The areas that we don't know much about that most of my colleagues and most of the specialists use for the support of miscarriage are things like hormone treatment like progesterone, HCG. A large number of works have been going on, but there doesn't seem to be any specific evidence to support this regime. I believe giving some of these medications will be what is described as a mental tonic effect. In cases where the cervix is very loose, getting a stitch onto it called McDonald's suture, this is usually administered around 16 weeks of pregnancy. And very rarely, if there is genetic abnormality, IVF might become necessary, and sometimes selection will be required, and that is called PGD, pre-implantation genetics, whereby you identify those cells that are completely free of abnormality before you use them in case of IVF. So in general, the prognosis is very good. About 50% of cases, you don't find any treatment. The absence of any cause of miscarriage should be viewed positively, because absence of pathology makes it more likely that future pregnancies will be successful. So finally, is it possible to carry a full-term baby after recurrent miscarriage? In most cases, the answer is yes. The chances of having a term pregnancy are very good, especially if no cause is found. In that scenario, 3 out of 4, that is 75%, will be successful in having a live-born baby. The chance, unfortunately, is less in older mothers and those with increasing number of miscarriages. Individualized chance of live birth could be discussed with your specialist. There are a number of supporting companies and groups. And if you want any more information, a lot of resources are available with Miscarriage Association. They have loads of resources that can be useful for patients that have relationship problems, because miscarriages can cause a lot of, a lot of problem with relationship. Relate is one good one that can support you. For those with emotional problems, the Samaritans are very good with providing emotional distress. And I can take any questions, and I think I will end my discussion here. Thank you very much indeed.
Thank you so much, Ibrahim. That was fantastic. I think we've had a really, really excellent 2 talks, and that has generated quite a number of questions. Some of them have come to me directly, some have been put in the general chat. So I'm just going to go through some of them now. So thanks to those that have given us some questions. I'm going to start off with some of the questions that have been put to Margaret. So Margaret, can you tell us why we have such high rates of obesity in the Black population? Is it more than in the white population? You talked a lot about food, and I know that we have any meetings, now they're all virtual unfortunately, but our meetings do have quite a nice menu when I go to them. So I know I look forward to the food as well.
I think, so firstly, Britain in itself, regardless of ethnicities, has the highest obesity rates in Europe, hands down. And ethnicity-wise, I'm not sure whether we would, in parallel with the white population, would have higher rates of obesity. But one thing we do know is that it's probably accountable for why we've been disproportionately affected. I mean, I know there's socioeconomic reasons where they've talked about overcrowding and housing, but when you look at the number of people that were affected by COVID, the vast majority of them had a higher body mass index, so were more obese than those that weren't being ventilated. So that was just fact. Someone's asked what's causing these high rates of obesity. And the bottom line is just that if you're taking in too many calories and expending very little, so you're not moving as much, your body's constantly trying to deal with an excess of calories, whether it's because the calories are high because of high sugar, high fat, complex carbohydrates. A lot of our foods now, we have something called you'll know, Gary, cassava root, which I've tried to ban from the house. We'll have it maybe once a month or something, because it's very, very high in carbohydrates. So 80% of the reason why obesity happens is attributable to food. Yes, there are some conditions. So if someone's got something called an underactive thyroid gland, you're more prone to gain weight. But however, in general, that's a very, very small percentage of people. And the biggest reason, Ngozi, is purely because of the food choices and the lifestyle and decisions that we're making.
Okay, thank you for that. Dr. Ibrahim, one of the things that you said that really struck a chord with me, and I think Charles asked the same question, is that you have to wait for 3 miscarriages before you're given the sort of the terminology of recurrent miscarriage. That must be awful for women who are experiencing these miscarriages, isn't it? You have to have 3 before you're investigated. Did you want to just expand on that?
Yeah, okay. As I said to you before, there is a sort of a variation between the nations. In this country, that is the current definition. But I think the goalpost is slowly changing on the basis of what you said. Because of the anxiety, the stress that the couples will have to go through, a large number of consultants, including myself, have moved the goalpost from 3 consecutive to 2. So the issue now is there's no consensus across the nations. The body of authorities for obstetricians and gynecologists in this country is Royal College of Obstetricians and Gynecologists. They've not endorsed the 2 recurrent miscarriages as 2 consecutive miscarriages as recurrent miscarriage. Until that is done, the definition will continue to be the 3. But my message to women is this: 1 miscarriage is bad, 2 miscarriages is just too many. If you put pressure on your GP and your consultants, I'm sure investigations could be started. But on the basis, let me just really address that now. If you investigate too early, the chances are that you find nothing, and that might give a false impression that all is well. If you defer your investigation until after 3 consecutive miscarriages, the chances of finding treatable conditions are very high. So you lose some, you gain some. You do investigation too early, you don't find anything. You do investigation late, you're able to find 50% of causes that are treatable.
Okay, thank you. I suppose that it is about an individual couple, because that individual couple, whatever is causing them to have recurrent miscarriages, that cause will be there after 2. So as an individual couple, if I'm investigated after 2 miscarriages, you'll find the cause, because it'll still be there after 3. So I know it's difficult. I think what you're trying to say is that you'll investigate many more couples if everybody comes after 2 miscarriages. But as an individual, I don't think I would have a family member or a friend who'd had 2 and say, wait, but I can understand the reasons, and that's a really good explanation. Now, we've got lots of questions about mental health, and I think there is a stigma about mental health. So once you say mental, even if it has a connection with madness, and one of our questions has been really put really well by Obi, so thank you very much for the question, Obi. And what she said is that most conversations I've had with most Black people, we don't really understand what mental health is about. We just understand it as madness. And in a sense, once you say mental, that's what people think, but it has a really wide range. And Margaret, would you like to tell us some of the things that we put under the umbrella of mental health that might present to you as a GP?
So it's a really important question. And I think it comes back down to the definition. Ngozi, you're 100% right. It's that word mental is just equated to madness. But if you look at the actual definition of mental health that either the NHS or World Health Organization give, it's a person's state of well-being. And that well-being could be emotional, social, or psychological. But it's your ability to deal with the normal stresses of life and interact well with yourself, your wider community. Once you've got a disruption in that system, because we all have a mental health issue at some point, and by that I mean this. So people commonly present with perhaps symptoms of anxiety. Now, before I even give a presentation, sometimes I'll be a little bit nervous about what I'm going to say or how I'm going to say it. However, if that anxiety now consumes me, that I can't function properly in my normal day job or at home, and this does happen, then it becomes an issue. Sometimes I'll feel a little bit sad. We all get sad, but how we cope with that, if the depression and the sadness becomes so overwhelming, then I'm now developing a mental illness. So there's ways that we need to address it with our community to perhaps think about changing the words. And I'm also conscious of when we have women that present in the late 40s, because we haven't touched on, I know there's so much to cover in an hour between myself and Ibrahim, they'll often come in anxious, they're crying for no reason, they don't understand why they're not being able to function. Sometimes they're given an antidepressant, but actually we don't address the issues of menopause with our population sometimes, particularly when they hit their 50s, because their mothers just went through it without any intervention. And so the common perception is that, well, I should just be able to get on with it. But the symptoms for actually mental illness, the reason why I'm mentioning menopause, can often mimic someone just going through the menopause. And once you've had a conversation with a woman and you've talked about things like hormone replacement, it's just amazing to see the difference. They, often they come back and they say, I'm a completely different person. I didn't realize the fact that lack of a hormone on my being can have such an impact on my mental well-being and how I interact with others. So I've gone off on a bit on a tangent then, but I thought I'd just...
That's the kind of conversations we have. In actual fact, the person I've invited next week is going to talk to us about menopause, because I think it's a big gap that people don't talk about enough. And again, because I think in Black women, many of our mothers just got on with things, and so that's the ethos you're in, and I thought it was important to address that. So we're talking about that next week. So that's great. So anybody who's here this week and wants to come and have questions for next week on the menopause, that's going to be addressed. The other questions that have been put to me is, are Black women more do they have high rates of cancers? But now, so someone said, is there a higher rate of stomach and liver cancer in Black women? Do you know whether that's true?
Not that I know of, not more or less than the general population, but I can look into that and I can always feed that back to you. But as I'm aware, there's not any increased risk of cancers for those particular areas in the stomach or the liver.
Okay. Ibrahim, can these, when you talked about a long list of things that can cause recurrent miscarriage, can these stresses also lead to preterm birth and high rates of stillbirth, the same things that record, or are there different things that lead to miscarriages and stillbirths?
Thank you, Ngozi. That's a very good question. Stress can cause quite a large number of gynecological problems, including lack of having a period, lack of having recurrent miscarriage. How does this happen? This is one of the reasons when patients have been investigated for recurrent miscarriage, the first thing you need to discuss with them is that majority of couples, when you see them, they blame themselves. It's me, it's my fault. Why is it always happening to me? One pregnancy loss is good. Second pregnancy loss is just too bad. So this degree of stress, when they then get pregnant, because they carry the message, that debriefment message, the message of sadness into the next pregnancy, this increases pregnancy loss. And that is why whenever there's a miscarriage, what advice do you give to couple? How soon can they get pregnant? When should they start having intercourse? And the conversation you need to have, there's no set time for starting to have this. The time can be set by you. When are you mentally ready to start another family? Because what you don't want is to carry the message of grief into the next pregnancy, so that the lady will fail to enjoy the pleasure of pregnancy. And each time I speak to ladies about pleasure of pregnancy, they say, you are a man, you've never been a woman. How do you know pregnancy is pleasurable? And I always respond to that is that it's physiological process. And my own feeling is that we should make the pregnancy very enjoyable to women. And anything that is causing displeasure, it is the failure of the obstetrician not dealing with it, maybe antenatally or even in labor. Labor itself should be completely painless process, because there are so many things you can do to encourage lack of labor. So to come back to the same questions, stress can manifest in several ways, and without any doubt, stress increases miscarriages, increases difficulty in getting pregnancy, because once you are stressed, you stop having any periods. If you don't have any periods, you can't get pregnant. If you get pregnant, you lose it very early. So stress is extremely important. And that's why towards the end of my presentation, I said psychotherapy is useful. This psychotherapy doesn't have to be a formal intervention with a registered psychotherapist. It might be having a conversation with friends, with colleagues, joining support group, and joining them and sharing problems. And they often say problem shared is problem solved. And that is why trying to alleviate the cause of stress increases the risk of getting pregnant next time.
Thank you so much. Thank you so much. That's a really good answer. Thank you.
Ngozi, can I just add to that? Because that's a really important point that Dr. Balaji's mentioned with regards to stress. Often you'll find couples going through fertility investigations, sometimes unsuccessful. And it's not uncommon when fertility investigations have all stopped and they go back to normal, that they'll have a spontaneous pregnancy, because the stress of going through it all has just been so overwhelming that nothing's happened. And another little side thing that is a bee in my bonnet, we also put a lot of pressure on our women from a very early age with regards to success, whether it's education, and then once they finish that, then it's starting a family. And then once, you know, if they can't start a family, they're stigmatized because of that. If they've got fertility issues that sometimes aren't even their fertility issues, even the women that have managed to have a child, the pressure to have another child. I think there has to be something, you know, wider discussion at some point on our expectations of our women, and just allowing them sometimes to just be, because the expectation of sometimes their families and societies on them does really affect their mental health. And that's just one of my things that I thought I'd like to mention.
That's an excellent point. As a, you know, as a Black woman, I understand, because once you finish your education, I got my degree, and the next thing people are asking, so yeah, you've got MBBS, but when are you going to get the most important one, MRS, Mrs., you know? And people say that jokingly, but that's much more important than your MBBS degree. And then once you get married, the next thing is, so when are you going to start a family? And you wait a couple of years, is anything wrong? You know, that's it. And then you have one and they say, oh, you need a brother for that one. It's constant. It's constant. Not from my family, I must add. In fact, my mum was the opposite. After I got married, I think I got pregnant 2 years after, and she said, so soon? Yeah. So I've got an individual question here, but I'm sure that this question speaks on behalf of many. And it's a question about what's the chances of conception and achieving a full-term pregnancy if you're over 40 with multiple fibroids that can't be taken out based on gynecological advice. I think this might speak to, when you're describing some of these things, Ibrahim, I wondered, is there any sort of calculator, risk-based calculator that you have that you can put in all the different problems that somebody presents with, and that can give you a sort of idea as to what path you go down? So I suppose if someone presents at 31 with current miscarriages, you might, 2 miscarriages, you might investigate that or think, well, things are going to go well. Or if you present at 43 with the recurrent miscarriages, you think, well, this is more risky. I'm going to say to her, you might as well go for IVF right now. Are there any risk-based calculations you can do? So a woman who's over 40, multiple fibroids, the fibroids have to stay. What would you say about the chance of successful conception?
Thank you, Ngozi. That's a very good question. I wish there was a multiple calculator that can put all the factors into one place, i.e. the age, fibroid, environment, socioeconomic status, and so on. But what is available is that you can actually base your risk assessment on individual parameters. And then you can put the parameters together and use that as a rough inference, but there isn't any calculator that put everything together. Age is probably the key. In terms of fertility, before 35 years of age is the key. After 35 years of age, there is progressive decrease in chances of conception. And there's a biological basis for that. If you consider the total number of eggs that a woman will have, you have the maximum number of eggs at the time of conception, at about 20 weeks when you are inside the womb. That is when you have the maximum number of eggs. And from then, the number of eggs rapidly decrease. And at the time of birth, you probably have about 1 million composite of eggs. And this is called ovarian reserve. And it is that 1 million eggs that you gradually lose until you reach the change. And that is why if you're really thinking about conception, having that conception, getting it and done with about age 35 is the key. Now, so if you have the age and you have other pathologies in addition to that, say for example, fibroid, the location of the fibroid is also important. Fibroid could be located inside the womb, within the womb, or outside the womb. The one that causes problem with miscarriages are those that are located inside the womb because they act as contraceptives, like IUCD. So that as soon as the fertilized eggs get into the uterus, they have no area of implantation and they are lost. And that is the way the IUCD works. So if you have age and you are over 35 and you have intrauterine pathology, that increases it. So in terms of specific number for miscarriages, what we know is that if a woman is 35 years or the man is over 40, the chances of having a recurrent miscarriage is in the region of about 50%. In terms of fertility, that decreases very rapidly. So if a patient approaches you from about 35 onwards, you don't want to waste a lot of time investigating and giving standard treatment. These are the patients you want to recommend in vitro fertilization early rather than later. And the logic is very simple. In terms of funding, NHS will fund infertility for one cycle before age 40. After age 40, you've got to look at it and fund it privately. So that when you are visited by a couple wanting to achieve pregnancy and they're approaching the age 40, you want to ensure you rapidly investigate them. When they are very close to the target of 40, you want to maybe just advise them to go for IVF in the first instance. As soon as they reach 40, I'm afraid in most postcode areas, you need to fund it privately.
Oh, wow, that's difficult, isn't it? Yeah. So, Margaret, there's another question, something you said about free health checks. Now, I remember when I was 45, I was just told to come to my GP. They did a, sort of body MOT. I had a blood pressure measurement taken, had bloods taken. Is that, did I understand that that's going to stop? Is that being phased out?
So it's not official yet, but I think there are certain noises being made about trying to phase it out. To be honest with you, not many people even really take it up. It's very rare that we've had people present and say, I've come from a free health check, if I'm honest with you. So I don't know, but I will keep you posted, because often the check involves your blood pressure, weight, and they check your to see whether you've got diabetes or high cholesterol.
That was it.
Sometimes we have found people who've just been floating around with diabetes and have been none the wiser. So I'm hoping it does stay around, but with all the government cuts and funding issues that we're going to have post-COVID, who knows? So
my concern now is that I think cardiovascular disease in Black people seems to be higher in terms of hypertension. So are some of these identified at the health check? And if we get rid of the health check, how will we know? How else are you walking around? Because blood pressure is not one of those things that announces itself. You very often don't know you have it.
Absolutely. In fact, one of the words is silent killer, which is quite a shocking terminology. What I advise all my friends and family to do is to get their own monitor. In fact, their own blood pressure monitor. You can pick them up now on Amazon or Aldi, Lidl for between £15 to £20. And there's lots of evidence now to suggest that patients who measure their blood pressure at home, it's a far better, truer record of their actual blood pressure than when they come into the surgery. And because we know there's this phenomenon called white coat hypertension, when someone's in front of a medical professional, their blood pressure just tends to go through the roof. So we really work on the recordings of people measuring their own blood pressure from home. So if you can access one of those, that would be my first recommendation. However, if you can't, then don't worry. You just ring up your GP and say, I would like to have my blood pressure checked, please. And that should be offered to you. It not even should, it must be offered to you, particularly if you're at risk. And also, if you're worried about your risk with anything else and you want to have a check, whether it's to check you're not diabetic, to check your cholesterol status, again, explain that you're worried. And I can't see anyone refusing you on the grounds of wanting to get checked, particularly when we know what our risk factors are. So please do that and ring your GP.
Okay.
If I would just contribute slightly there, Ngozi.
Absolutely. Thank you, Ibrahim.
Okay. So one area which I found very interesting was a meeting I attended in the US last year, which is called religious site intervention. These are private individuals who fund projects. These projects are then put in Black areas in churches and mosques. When they get to the mosques, they have a group of healthcare professionals in the church and healthcare professionals in the mosque. They offer them free healthcare check, including blood pressure and blood test. And the uptake is phenomenal. In this scenario, in a population in Atlanta, for example, with a population of about 200 people that were investigated, completely unaware of their hypertension, 52% of them were found to be very hypertensive, to the extent that from the time they obtained the result, they offer them treatment within 48 hours. So these are other areas, although GPs are very good, the access is very good, but quite a number of people are reluctant seeing the GP, especially the men. But we do know that many of them are good attenders to churches and mosques. And if there's anybody out there has got a bit of funding, if you really want to set up a sort of healthcare services in religious areas, that would be a good way of spending your charity money.
Thank you. That's a point well made. And
I think, Ngozi, someone's just put something amazing in the chat about CAHN nurses having gone to local churches. Faye Bruce. I mean, that's amazing because that's place-based care. That's where you want to go, really.
Absolutely.
So it looks like what Ibrahim's described is happening. Yeah.
So
Thank you.
Faye was the. Faye, do you want to, where are you, Faye? Do you want to say a few words about what you've done with this? And this is what her PhD was based on.
Hi, Ngozi. Yeah, yeah, no, some brilliant work. I just commend the CAHN nurses here, because they went out religiously every so often to churches and community centres and did this screening. And Vanessa's on the call. But yes, it was when we tested people's blood pressures and, you know, for AF as well, you know, over 40% of those people were referred to their GPs, and many of them were under 40. So I had this thing about, you know, why aren't we doing testing earlier when we know our Black people are more likely to have CVD related issues earlier. So yeah, no, some brilliant work, but yeah, we need to do a lot more of that.
Vanessa.
Hi there. Good morning, everyone, and thanks for a really interesting call. Just on the back of that, it's looking at younger people, not just under 40s, but real youth. On one of the church screenings that we did, there was a 15-year-old lad, rugby build, looked healthy. And when we did his blood pressure, it was quite high. We repeated it 3 times in that one session, and it was pretty high. He got referral to Salford, and it found out that he had an underlying condition. Had we not gone to the church and screened him, he would have just gone along, did his sports, and probably ended up with a heart condition, if not die. So it's really important to screen not just under 50s, but young people, educate them about health, etc. And that was one of our outstanding moments, success stories. And we've seen that young lad since, and he's still under investigation. Had CAHN not set that up and as nurses gone in to screen, that young person would be walking around with an underlying condition that they didn't know anything about.
Thank you very much, Vanessa. Thank you for sharing that. Dawn, thanks for what you've said. I can see we've received some funding to examine feasibility of establishing community dementia care hub in Black majority churches. That's amazing work that CAHN is doing. Now, I thought we've had such a really fantastic session. There's just been so much engagement and so much really good information that we've had today. And so CAHN has put some flyers in the chat about bereavement care, emotional well-being that we have, our domestic violence, and our International Women's Day event. So I think just to finish off, I'd like to thank our speakers, but I'd also like to say that whilst this is International Women's Day, I know that we'd like our men to be involved as well, because Ibrahim has also talked about, when he's talking about infertility, although the burden seems to be on women, very often we don't talk about the age of men and problems that might be affecting men in terms of infertility. I think they should be viewed as a couple, and we need to make sure that our men are supporting our wives and partners, but also supporting our women in a sense, so that when they're not feeling well, that they should be encouraged not to go and see their GPs, give them a break from looking after children and doing things in the house, and be there as a true partner and a couple. So our International Women's Day, although it is a day celebrating women, we want to involve men in that as well. And that's why I asked you to come as well, Ibrahim, because I think it's important that we involve everybody in order to celebrate our women. So thank you so much for this event, and thank you for coming. Our sessions in the next week are really great. So next week we have from periods to menopause and beyond. So I invited Dr. Bim Williams, who works at Bolton, and she's going to talk about that. And as I said, I think the menopause is an underrepresented area because people feel they should just get on with it. The week after that, you know, we as Black women, we've always said that we like to celebrate our hair and wellness and skin, and we've got a specialist coming to talk to us about conditions that affect Black skin and how to take care of them. And on the 27th of March, we'll have Dr. Vanessa Appiah, who's going to talk to us about sexual health. So any questions that you have, any areas that you'd like us to address, please get in touch with CAHN and let us know. I'd like to say some of these sessions, if you are nervous about putting questions in because you don't want to be identified, I think that might happen in our Sexual Health Week. Change your name on your Zoom or submit your questions beforehand anonymously, because we'd like all our sessions to be as interactive as possible, and we really would like to get as many questions from you as possible. These sessions are for you. And lastly, this is for the month of March. In the month of April, to redress the balance, I'm going to have a session on men's health, and we've got a urologist booked in to talk to us about problems with the prostate and urological problems in men. So that will address the balance a little bit. So women that are here, please get your men to come along. And I'm also going to try and arrange a session on sickle cell, so with a pediatric and an adult hematologist as well. So thank you so much for giving up your hour on a Saturday afternoon, and enjoy the rest of the day. I'm just going to hand over back to Charles to say a few words. And thank you so much, Margaret and Ibrahim. It's been an amazing, amazing, amazing session. Thank you.
Thank you, Ngozi.
Thanks, Ngozi. I wonder if Professor Donnerge, you want to say a few words about your research?
Oh, I didn't see that in the chat. Sorry, Dawn. Is Dawn here?
Sorry. Hello. Thank you for that. Just unmuting. Thanks for the opportunity to share. So it was really interesting to hear what was being said about working with churches. So we've been doing that for some time now, and we have developed with people from the community a form of psychological therapy, talking treatment, working with members of the community for families affected by schizophrenia and psychosis. We've had to pause. We've got a national trial or intervention now. Got funding for that, and we should have started, but we've had to pause due to COVID, and God willing, we're hoping to get started in July. I'm happy to come back, Charles, if it would be helpful, and tell people a bit more about that at another time. So yes, just watch this space. I'm obviously happy to share it via CAHN as well.
Oh, I think that would be fantastic, Dawn. And if you could contribute to one of our sessions, that would be great. And I'll get in contact with you. That would be really good if you could. Thank you so much.
No problem. Thanks, Charles. Thanks, Ngozi.
Thanks, everyone. And just to remind you all, for those who haven't booked for the IDOB International Women's Day event on Monday, please don't miss it. The link is in the chat box. Please book, and we look forward to seeing you there. So once again, to Ngozi and our guest speakers, thanks for giving your time. Today's session, as with previous sessions, will be available, right away on, our YouTube channel. So please make sure you have a look on the YouTube channel and share with your friends and your family, members who weren't able to join. Until then, look after yourself, hands, face, space. If you have any concerns about receiving the vaccine, then you can see lots of doctors here. We've all had it, and we're still here on planet Earth. So if you have any concerns that needs addressing, or if you feel, yes, I mean, the question we're asking now is, what could we do to encourage those who haven't made their mind to make their mind to receive the vaccine? And there are doctors, not just in Manchester. You've seen Dr. Margaret from Leeds, and I don't know where Dr. Ibrahim lives, but there are doctors and GPs up and down the country from our communities, that can offer you some reassurance. So till then, let's look after ourselves, and we will see you on Monday. Thank you.